And a new prostate cancer study shows that surgery does not appear to have actually saved the lives of some men who are in early stage of the disease. In fact, many of those men would do just as well if they chose to have no treatment at all. Dr. Nader Javadi from the Beverly Hills Cancer Center is a cancer specialist. He is among the pioneers, actually, in prostate cancer treatment, and he is in studio with us tonight.
Good evening.
Doctor, welcome.
Thank you.
Let's talk about that. I mean, what was the old treatment for prostate cancer?
This has been a controversial area in the treatment of prostate cancer. For decades, when the prostate cancer was being diagnosed at early stages, patients were facing two options, either radiation therapy or surgery as a local therapy.
And the surgery would remove the prostate or remove the cancer around the prostate?
The surgery would remove the whole prostate and sometimes the tissue around it. And radiation therapy basically is external beam radiation, which was locally focused on the prostate.
And the new thinking is just watch it and see how it develops?
We had this question for years that whether if we detect prostate cancer in early stage, can we improve the survival by giving them radiation or do the surgery? And this question was basically addressed in 3 randomized trials. 2 of them actually were before the era of PSA screening. PSA screening is the most common screening right now for prostate cancer. And the most recent one, which was done after the PSA era, showed that in early stage of prostate cancer, if you remove the prostate by prostatectomy, actually is no better than just observing the disease.
We're back once again talking about prostate cancer and the study that really indicates you don't necessarily have to have radiation or surgery. What really, you know, that's the way that people used to handle it. We were talking about that before I got so choked up here. But what's the downside of having radiation or surgery on the prostate?
These are local therapy in general. They focus only on the prostate and prostate bed. Basically, for years we noticed that people are going under surgery or sometimes radiation therapy, they may develop erectile dysfunction or impotence or urinary incontinence. Those patients who may go also radiation therapy, there is a risk of burning the tissue and secondary cancer, especially colon cancer, but very limited data on that. And new technology for radiation has tried to reduce the side effects in terms of the local therapy. However, surgeries, the side effects on that is still going on, and we have a certain percentage of these side effects, including the erectile dysfunction and incontinence. So down the road, these side effects may be a major impact on the patient's life.
So how do you treat prostate cancer if someone comes into you and they are in the early stages here? Is it simply...
This is the main question addressed by the recent trial published at New England Journal of Medicine by the name of PIVOT trial, Prostate Cancer Intervention versus Observation trial. Basically, they randomized patients to 2 groups, one surgery and one group observation. And they noticed patients with a low-risk disease or the PSA less than 10, the surgery was actually no better than just observation, no impact over survival. However, there was a subset of the patients who had PSA more than 10.
More than 10.
Or they had a high-risk disease, high-risk features, the pathology was more aggressive feature. Those patients actually, they benefited somehow from the surgical resection.
Well, is prostate cancer a slow-growing cancer? Is that why this is such...
That's a good question. Prostate is a spectrum of disease. It is not a monolithic disease, which means that in one end we have a slow-growing tumor, and in the other end we have a very fast-growing tumor. PSA generally detects slow-growing tumors. So when we are facing a fast-growing tumor, PSA may not detect it.
Sure.
So the future trials and future treatment plan should be focused on a high-risk patients who have a high-risk feature, high PSA, to detect them early on and treat them effectively. So now the take-home message from this study and the prior randomized trial is that if a man is diagnosed with prostate cancer today and his PSA is less than 10 and he has low-risk features, this patient should pursue observation viably because this is a viable option for that patient. There are some studies now underway that they detect active surveillance against surgery. You know, observation, they're waiting until the cancer shows itself by symptoms or high PSA. Active surveillance means that you detect, you check the PSA every 3 months, and you do biopsy as needed. If you take that approach, compared to surgery, will be another trial which give us a better answer of how to approach this
That
disease.
has to be a tremendous relief for someone who comes into you and you discover he has prostate cancer.
Yes, exactly, because in the patients when are diagnosed, people diagnosed with prostate cancer, men, they're anxious. They think they have to get rid of this cancer as soon as possible. So they take options like surgery and radiation therapy. But they don't know if they are not a high risk. They can live with that cancer for years. They may not need any treatment at all. So that study published at New England was trying to address that question, that you don't have to have surgery or radiation if you're low risk. You do as well as surgery. And given into perspective that surgery is not risk-free.
Sure.
You may get impotency, you may get urine incontinence or infection. There was one death in that study in basically surgery arm.
Doctor, thank you so much.
My pleasure.
I was just living through this with a friend of mine, so you really put it into perspective for